Hello, my name is Dr. Fernando Bonani, and I am a board-certified surgeon and the medical director of the Blessing Bariatric Institute. And I'm proud and pleased to present to you the new obesity program at Blessing. We are a team of dedicated providers. We're dedicated to the disease of obesity and focused on its prevention and its treatment. We offer a comprehensive lifetime care of the obese patient that involves education, medicine, and surgery. And we're excited to be a part of the new changes that will come in your life from weight loss. Our mission is comprehensive and compassionate lifetime care for the obese patient. We are well suited for this because we understand the disease of obesity, and we understand that obesity is a genetic disease that's lifelong and it requires lifelong treatment. Unfortunately, patients often come to us with many barriers that we get from society about the stigmata of obesity. Patients come with a guilt about their weight, that somehow it is a gluttonous problem and that they're responsible for their weight loss. And they often hear things like, just stop eating. Why are you going over the top? Or this is really over the top doing surgery for losing weight. Just stop eating. These are the kind of things that patients that are obese will hear all the time in society, both from family and friends and people in the workplace. And so they come with a hesitation as if maybe this is their fault. And this problem really comes from a lack of understanding the disease. And what those people don't understand is that obese patients are constantly fighting the storage of excess energy in the form of fat that their body is trying to constantly preserve. So although I understand the impression that maybe surgery is over the top, I think what we really need to understand is that the disease is over the top. Over the top, to me, is an epidemic where we lose 400 to 500 people every year to related deaths. It's the #2 preventable cause of death in this country and in the world. It's an epidemic that is soon to be out of control. We know it to be the #1 contributor to all the diseases that take our lives, such as diabetes and heart disease, early cardiac sudden death, lung disease, liver disease, and early orthopedic problems and limitations. This is an epidemic in the US, but it's also an epidemic in the world. In our country, over 60% of people are overweight and 35 to 40% of people in America are obese. And now 1/3 of our children are overweight. 15 to 20% of our children are obese. So this is a growing epidemic, but it's an epidemic of a disease that we know shortens the length and the quality of life. So when we want to compare over the top, we need to think about only one thing. If you're 100 pounds overweight for more than 5 years and you're under the age of 45, you can lose up to 22 years of your life. So the resistance to this treatment is the problem of not understanding the disease. So the real problem is that it's very hard to associate eating too much or being overweight with diseases. People have a hard time understanding why eating too much contributes to high blood pressure or breast cancer or heart disease. It doesn't connect for people. So I usually use a pretty simple analogy. Anything with systems that are overloaded is going to fail. For example, an automobile. If you were to go into your parking lot and get into your car and there was another car on top of it, you can pretty much guarantee that the tires, the gas, the engine, the transmission, all the system support that car needs to go is going to be strained. And we could pretty much be sure that the car is not going to last as long and that all those systems are going to fail. So just like the car analogy, the human body is made of systems that we call our metabolism. For example, our heart, lungs, immune system, endocrine system, muscle system, and our skeletal system. So those systems we refer to as our metabolism is what keeps us alive. So the overload of any system is going to cause failure, and that's why we see so many diseases related to obesity. And just for a few examples, diabetes means that their endocrine system got too much pressure. Early heart disease suggests that our cardiovascular system is overtaxed. Early aggressive cancers of any kind is because our immune system is overtaxed. So just like the car, when our systems are overtaxed, they fail. And that's why we see diseases in all those systems. Surgery has a long history, and recent advances, along with a comprehensive preparation and follow-up, has recently enjoyed some very good results with very low risks. In fact, recently, studies have shown that bariatric surgery have a mortality rate equivalent to that of a gallbladder. So when you look at the over-top comparison, obesity has got much more risk than surgery over a lifetime. So obesity is the real risk. I'm not saying that surgery does not have risk. Certainly it does. But when we look at the outcome of obesity, those risks are much, much greater than undergoing surgery. But what's really important is that you undergo surgery in a comprehensive preparatory program that offers follow-up for a lifetime. It's also very important to make a commitment. Your surgeon and your program make a commitment to you, and you make a commitment to your surgery lifelong. So our treatment goals really is to reduce the load on your metabolism. This decreases diseases in your systems. It increases the quality and length of life so that patients can get to more normal risks in their lives. This is not going to prevent diseases, but it will prevent diseases that are exacerbated by having an excess weight that's making our systems fail earlier and decreasing our quality and length of life over time. And what we do know about surgery is that once a patient has reached a certain point in being overweight, that it really is the only treatment that works long term. So the question is, when do we do surgery? I like to call that the point of no return. There are some guidelines. They're not perfect. But basically, a body mass index of 40, or about 100 pounds overweight, is a point of no return. Another point of no return is a body mass index of 35 with diseases that are severe. Other treatments in patients like this don't work as well because it's difficult for other treatments to impact on all your systems all at one time. And so what we know that without surgery in the morbidly obese patient, as I just described, body mass index of 40 and body mass index of 35 with disease, is that the chances of losing 1/3 of your excess weight over a year's time is 5% if you're 45 or younger, and less than 5% if you're over 45. Now, of course, this is not to say that diet, exercise, behavior modification, medications are not important. They are absolutely important, and they're a big part of our program. But they are a part and in partner with surgery. And we have experts that will provide education and treatment in nutrition, behavior, and medicine. And they will guide your treatment and your success over time. So it's important to understand that diet and exercise and behavior modification, and sometimes medicine, is necessary for success. But it's a partner to surgery in patients that have hit the point of no return. We use two basic principles in bariatric surgery. One is called restriction, and the other is called diversion. Restriction is just a fancy way of saying that we make your stomach smaller. Our stomachs are designed in such a way that there are nerve endings in the lining of the stomach. And so when the stomach stretches from food being in it, it tells our brain that we're not hungry. And they're called stretch receptors or baroreceptors. So the idea is that we decrease the amount of calories you take in by volume with a smaller stomach, and you get satiety sooner. The other principle is called diversion. And that's really a fancy way of saying that we rearrange the intestinal tract in such a way that food enters the GI tract, but it enters it further down. And this changes the response that your body has to food. First of all, it does three things. It diverts calories by skipping over areas. Then it has a direct impact on the gastrointestinal hormones that communicate with your brain and changes their response so that you become more efficient in metabolizing carbohydrates. And lastly, you get satiety from the intestinal hormones from the lower intestine. Of course, with diversion, that's when it's important to replace essential nutrients with supplements. The most important thing is the program and its comprehensive approach. The basic pathway is a patient becomes interested, is deemed to be a candidate. They come through the door and we decide and we figure out whether they just need medicine, surgery, or both. They undergo an information session where they're educated about obesity, and then further interest leads to a nurse's interview. And after the interview, basic lab tests and x-rays are done to try and diagnose the severity of other problems related to obesity, which we often find many. Then you undergo nutritional education to learn about basic nutrition and the surgery that you're considering. You'll see a psychiatrist who will determine whether or not you have what we call contraindications to surgery. There'll be a social worker who will be involved in your case from beginning to end, who will assess all your support systems and help you through the surgery and help you get the support that you need. Then you'll see the surgeon, and between you and the surgeon and the team, you'll pick a surgery that's based on you. Every surgery has its positives and negatives, advantages and disadvantages. It's really important to know all of them before you make those decisions. And then once you've decided on the surgery, you may be going to see specialists like heart doctors and lung doctors and endocrinologists, diabetes doctors, and blood doctors. It really kind of depends on what the lab tests show us and what your medical history is. And then all those people will come together and bring you a plan that can get you through as safe and healthy as possible. Your surgeon will do an endoscopy, which means looking into the intestinal tract. We will look into the stomach to make sure that you don't have anything in your stomach that requires treatment before surgery. And then lastly, you'll go through an education process where you'll learn about your surgery and your whole pathway. And you'll take a written exam on your particular surgery and what you're expected to run into throughout your journey. So the surgical decision is a team decision, and it's done with you and the surgeon together. We all agree on the surgery. And if we don't agree, we talk about it. What's most important is that you learn about your disease and your surgery, and that you make a commitment, that your surgeon makes a commitment to you, your program makes a commitment to you, and you make a commitment to success. Success requires a good education, a good preparatory program, choosing the right surgery for you based on your problems, a lifetime commitment from the surgeon and the patient, and knowing your surgery. Congratulations on your decision on bariatric surgery. We're honored to be a part of you changing the rest of your life.